name is Francis Ochen from the African Society for Laboratory Medicine. I'll be a moderator for today. Our session will run for 1 hour. We'll take 2 presentations and get into the questions and answers. Kindly join the discussions through the chat and also keep to either one of the 3 language options that we have: English, French, or Portuguese. The slides from this session and the recordings will be shared with you. Today's session, we're looking at strategies to improve HIV testing services and the adoption experience of the WHO recommended 3-test algorithm from Malawi. And we know that over the last about 20 years, HIV testing services positivity rate in the sub-Saharan African countries have progressively declined from about 9% to about now 3%. And this decline is anticipated to continue if the current biomedical interventions and those yet to be deployed retain their potency. We are also aware that the treatment-adjusted prevalence, which really defines the population categories that we are targeting for testing, is even lower. And yet test validity, that is a function of sensitivity and specificity, is really dependent on the prevalence of the disease at any one point in time. And we're also aware that the WHO now recommends that all countries currently using 2 reactive tests to classify somebody as having HIV disease should actually move to the 3-test algorithm, where they use 3 consecutive reactive tests for an HIV-positive diagnosis. And the selection of the test devices or the kits that are supposed to be used or the combinations therein should be based on rational verification studies done either in-house or through the use of data that is available but comparable to the population that we are going to be deploying the test devices on. And so in today's session, we will share the adoption experience from Malawi and initiatives to improve general HIV testing services with the national level monitoring and improvement through HIV testing, our community of practice from CQUIN. And to take us through this, we have 2 presenters. One of the presenters is Dr. Rose Nyirenda, and Rose is the director of the National Program on HIV, Hepatitis, and STI with the Malawi Ministry of Health. She leads the Malawi program to implement effective and innovative work across the continuum of prevention, testing, and care. And the other presenter is Dr. Violet Oramisi, and Violet is the Regional M&E Advisor on the ICAP Multi-Country Learning Network, CQUIN. And Violet specializes in monitoring and evaluation of differentiated service delivery, and she provides essential technical support to countries and serves as the strategic information liaison, supporting the communities of practice that are run within CQUIN. Prior to joining CQUIN, Violet was the strategic information manager at the National AIDS and STI Control Program of the Ministry of Health in Kenya. So colleagues, join me in welcoming our presenters, and we'll start with Dr. Violet to take us through our presentation. Violet, over to you.
All right, so good morning, good afternoon, everyone. My name is Violet Oramisi from ICAP CQUIN, as I've been introduced, and on behalf of CQUIN, I will be presenting the CQUIN HIV testing community of practice, perspectives on the differentiated HIV testing quality. So this is the outline of our presentation today. We will have a brief introduction to what is CQUIN, the CQUIN approach, the CQUIN differentiated dHTS capability maturity models, and mainly focusing on the quality domains. And we will also be looking at the quality of HIV rapid testing, cross-cutting concerns. So CQUIN is the coverage, quality, and impact network that is convened by ICAP and funded by the Bill and Melinda Gates Foundation. And ICAP provides the technical assistance and thought leadership. We have an advisory group members, as well as global partners that include WHO, Global Fund, UNAIDS, USAID, among others. And we utilize as CQUIN the 3 capability maturity models for treatment, advanced HIV disease, and HIV testing. And today we are going to delve a little bit more deeper into the differentiated HIV testing capability maturity model. Our main goal as the CQUIN Learning Network is to increase coverage, quality of HIV person-centered services, leading to enhanced health outcomes and program efficiencies. So from the capability maturity models, we're able to see that countries come up with their differentiated DSD action plans, and this now guides how the network prioritizes the activities. And of importance is to note that the Ministry of Health are usually our primary stakeholders that do lead the country engagements with the key country stakeholders that includes recipients of care, PEPFAR agencies, and implementing partners. So as shared earlier is that the main goal is, the goal is impact. And we see that when we have coverage and quality, then we are able to get the impact that we all desire to have as programs. So in this slide, we're able now to understand what are these capability maturity models, the 3 that we have talked about. So CMMs, the short form of the capability maturity models, is a system strengthening approach that helps us identify what are the core functions, what are the domains in which capability is required for us to achieve organizational goals. And when we look at these domains, we are able to describe them in sequential stages of maturity within each of the domains, and then set clear paths towards how we achieve maturational goals. And this is used repeatedly on an annual basis to be able to track change. So the capability maturity models have 5 stages, ranging from red to dark green, where red represents the early or the preliminary stages of planning and development, and is useful for us to be able to identify what are the next steps to take in order to be able to scale up that particular process. And in dark green, where now we have been able to achieve a most mature score. So then how do countries use the capability maturity models, or how do we use this? So on an annual basis, there's systematic self-assessment of the national differentiated DSD programs to be able to see how are we programming or how are we progressing as countries. And we have a multidisciplinary team from the countries that do sit down to do the self-assessment, including the recipients of care. So it's compared on a year-to-year basis to be able to track the maturity of the national DSD programs over time. This enables countries to use the same terms and indicators to help them identify what are the areas of shared interest or challenges. This then enhances friendly competition and also diffusion of innovation among the countries. And countries therefore utilize these results to prioritize what are their DSD priority activities that they include in their country action plans. So this slide displays the scores from the current differentiated dHTS capability maturity model self-staging among 21 member countries. It also highlights all the 22 domains within this capability maturity model. The rows here that have been highlighted represent the 22 domains, while the columns represent the countries. And we can appreciate the diversity across the scores in the different countries across the 22 domains. The first 12 domains are the enabling domains, while the last 10 domains are the outcome domains. And quality domains, the 3 quality domains fall in the outcome domain section. So in the next 4 slides, we are going to delve deeper into the scoring of the 4 quality domains. And we will be starting with this domain on policies and guidelines, optimizing HIV testing. So in this, we see that for a country to have a dark green score, it means that the national policies and guidelines do recommend the normative guidance on HIV rapid testing algorithm, active case finding, and prioritized group for repeat testing, and recommends integrating HTS into other services. So we can see that if you score red in this particular domain, it means that the national policies and guidelines include only less than 2 of the normative guidance or recommendations that are described below. One of it, for example, if you look at the normative guidelines number 1, it's talking about that the national testing algorithm consists of the 3 serial validated rapid diagnostic tests to confirm the HIV positive status. And during the introduction, we saw the new recommendation from WHO that we move from 2 to 3 test algorithm. This second quality domain that we are now looking at is talking about the quality of testing services. One, where we are looking at the external quality assurance and the internal quality assurance. For a country to achieve a most mature score, it means that it has external quality assessments and internal quality control program that regularly assesses the quality of the testing sites and ensures that they meet the national standards. So if a country scores any other score, for example, red, it means that that particular country does not have external quality assessment or internal quality control program for HIV testing. The third quality-related domain that we are looking at is quality of testing services, where now we are looking at proficiency testing. For a country to achieve a most mature score, which is the dark green towards your right, it means that the country has been able to develop proficiency testing systems, which regularly, as per their national policies, assess and certifies the competence of the testers on HIV rapid testing, including both point of care testing providers and also laboratory personnel, and they have been able to achieve more than 90% of the testers achieved the acceptable pass rates. So that is the most mature. For a least mature, which is the red, it means that the country does not have a proficiency testing program for people providing HIV testing services. So you're able to score all the way from red to dark green. The fourth quality-related domain is the one on quality of testing services, 3 on clinical services, where we are looking at having strong evidence that differentiated HTS meets the quality standards based on the 5 Cs, which are consent, confidentiality, counseling, correct results, and linkage to post-test services, and that the sites are offering dHTS meeting the minimum standards for safe and ethical HTS. So we're able to see that even if you have conducted, for example, your SQA toolkits have been used to conduct at least one of the evaluations on the differentiated HIV testing quality using your nationally representative sample, and in that year, you're able to see that more than 75% of your HIV testing sites were assessed and they were able to meet or exceed the quality standards. So in this particular domain, now you're able to score based on what assessment you conducted and the scores that you're able to achieve in that country. So then what are we seeing in this slide? This slide is showing us the differentiated HTS capability maturity model scores across 2 years. We're able to see the trends that are stacked by stage and not by country. And highlighted are the 4 quality domains. The first domain is the second one under the 3 policy domains that we have highlighted, optimizing HIV testing. and the other 3 falling under the outcome domain sections. And what you're able to appreciate also is that toward the left of your screen are the 22 domains. And then here we are now able to see that the results have been stacked by maturity, starting from dark green all the way to red across all the 22 domains, but we have only been able now to highlight the 4 quality domains. And what you can appreciate here is that we are seeing improvement between 2023 and 2024 in terms of what the countries were able to achieve as their scores for these particular quality domains. In this slide, we are now just looking more closely at the 3 outcome quality domains, and this is mainly the external quality assessment or the internal quality control. We're also looking at proficiency testing and the clinical services quality domain. And we are seeing the comparison between the year 2023 and 2024 across these 3 quality domains. And we look at the first quality domain, which talks about external quality assessments, where the program is regularly assessing the quality of testing sites and ensuring that they meet the national standards. We are seeing an improvement between 2023 and 2024 across all the 21 countries that we have in the network. And we see, like, for example, last year we had 2 countries that had a red, but this year we only have 1 country that scored a red. And also we have an increase in the number of countries that had dark green from 4 to 4 this year as compared to 3 countries last year. The second quality domain, proficiency testing, which is assessing the program, how it is regularly assessing testers' competency to ensure that they meet the national standards. We are also seeing an improvement. For example, the number of countries that had a red score in 2023 and 2024, this has reduced from 4 to 2. And in the last score, which is the clinical services, where we are looking at if they're able to meet the quality standards for the 5 Cs, and the sites are offering dHTS that meets minimum standards for safe and ethical HTS. We also note an improvement, especially when you look at the number of countries that scored a dark green. When you compare 2023 to 2024, majority of the countries now have improved in their scores, and we also have only 3 countries that had scored a red in this particular year for this particular domain. So then how have we been supporting the countries, and how do we continue supporting the countries as the CQUIN Learning Network when it comes to this capability maturity model on the differentiated HIV testing services, among other assignments that we do, is that we offer technical assistance for countries to conduct these self-staging meetings. The second thing is that we do offer focus country technical assistance to address the identified gaps, and that helps the countries improve as they identify what are our challenges and what do we need to do to be able to address our gaps. We also collaborate with stakeholders, for example, the way we are collaborating today, to ensure that we are able to support countries improve on how they are performing across the different capability maturity models, including the differentiated HIV testing capability maturity models. And also, based on the work that we do, we convene quarterly community of practice calls to co-create tools and resources. And we also prioritize webinars that are demand-driven based on the priority topics. As CQUIN, we also do convene meetings, and we also support country-to-country learning exchange visits, where one country is able to identify what is our gap, which country is doing very well in this particular area, and they're able to visit that country to learn from them. And we also do support sharing of tools and resources among countries. So then what next as the CQUIN Learning Network? One of the things that we are now prioritizing is the differentiated HTS meeting that is going to take place in July in Durban between 9th and 12th of July. So in this meeting, being one of the things that we do as CQUIN, we are prioritizing the exchange of best practices, innovation, resources, tools, and job aids that are related to DSD. We are also going to facilitate discussions on strategies to enhance coverage and quality of HIV testing services, strategies for expanding HIV self-testing adoption. Countries are also going to share what are our gaps, what are our challenges, and what are some of the opportunities that do exist for future joint learning. And we are going to support the countries be able to develop country-specific action plan based on the current scores that we have shared with you today on the differentiated dHTS capability maturity models that will align with their program priorities and activities so that they're able to scale up quality and equitable person-centered services for all subpopulations. Thank you very much, and back to you.
Thank you very much, Violet there. Now we will continue encouraging colleagues to please put your questions in the chat so that when we do the second presentation, we'll come and deal with those questions. Again, just to note that this session is proudly brought to you given the generous support from the Bill and Melinda Gates Foundation to ASLM through the LabCoP project. Now, let me get it to Rose. Rose, you can take it on from here, and then we'll get to the questions and answers after your presentation.
Thank you, Francis. And thank you, the organizers, for allowing Malawi to share its experiences. I'm presenting on behalf of everybody that is listed. The Department of HIV, the Ministry, ITEC, QED, and also University of Washington. So we have all collaborated in this presentation. So, just a moment, our laptop is stuck. Okay, apologies. So this slide has already been, I think there was already a lot of talking from Francis regarding this slide. We are coming from a two-test algorithm, and after WHO provided guidance, as Malawi, we were one of the countries that were meeting the criteria. In our 2023 HIV testing guidelines, we fully transitioned from a 2 to 3 test algorithm. In terms of our rationale for the 3-test strategy, Malawi is one of those countries among several that we've been observing a declining positivity among people tested. So we have almost 91% of all people living with HIV were diagnosed and 84% on ART. And if you can look at the chart, you see that if you refer to the yellow part of that chart, which is showing HIV positive is not on ART. The green is the HIV negative population, and the purple are those on ART. So we have that little slice that we're supposed to target. So we are looking for those people who are positive out there that we should diagnose. And these are, we are looking at fewer people that need to be diagnosed. But also, if you look at this slide, again, our rationale was the declining positivity in the national program. If you can look at this slide, you find that from 2012, we had high positivity, but we've seen the decline. By 2023, we had 1.8, but from 2019, we have been at 3. We've been static at 3. And that was the whole reason why we needed to move to the 3-test algorithm. So overall, by 2023, we have had 3.3 million people tested. This is a 49% increase from 2023, and also 68,000 new positives, with a 52% decrease from 2013. This other slide is just showing the positivity among testers. As shown in the chart, again, it's seeing a decline, while the other chart is referring to the positive predictive value. And the red line is the 2 tests and the blue line is the 3 tests. You can see the PPV, a 2 test versus the 3 test. Again, just to talk about PPV, that's the probability that someone with a positive test result is truly infected. And it critically depends on true HIV prevalence among clients tested. So PPV drops for any testing algorithm with a declining prevalence. And WHO 3-test strategy ensures that PPV remains above WHO's 99% threshold. So this slide is just showing what WHO minimum requirement is in terms of the HIV rapid test kits. The rapid test kits have to be 99% in terms of sensitivity and 98% in terms of specificity. So for the Malawi 3-test strategy, we are using determine as the first test, Unigold as the second, and SD Bioline as the third. For the first test, it's after evaluation, it was highly sensitive. We are looking at high sensitivity, and for Unigold, high specificity, but also third test, which is SD Bioline, highly specific. All these rapid test kits were evaluated by our lab, our reference lab, and these were the choices that were made based on the results amongst the many other tests that were evaluated. So this chart just shows the algorithm that we have adopted in our new guidelines. They are demonstrating the first test, which is HIV test 1, the second test being 2, the second test being HIV test 3. So on my left, that could be your right probably, where you are seeing green, you are looking at a test, the first test which has been done, which is non-reactive. And once the first test is non-reactive, I think the rest follows as non-reactive. It will obviously be non-reactive. But on the other side, after the first test, if it is reactive, then a second test is run. And if it is reactive again, then a third test is done, reactive, and the protocols follow in terms of standard operating procedures. If test 1 is reactive, and then the test 2 is conducted again and it is non-reactive, then you go back to test 1. If it is non-reactive, then you can see that the flow chart follows. But if it is reactive, then it is considered inconclusive. Similarly, if HIV test 3 is non-reactive, it is also considered inconclusive. And usually that client comes back again for a repeat 3-test algorithm after 2 weeks. And if the repeat is still inconclusive, then a DBS sample is collected for testing at our HIV reference lab. And usually this is now a DNA PCR test. So that is now, that is the flow of our 3-test algorithm. I will not refer to the other components because you can see that within our algorithm, we also included syphilis is somewhere because we're also testing for syphilis and hepatitis B, particularly for antenatal women, but there's also research. But I think the main focus for this presentation is the 3-test algorithm. So what has been Malawi's transition journey? So as I mentioned at some point, the first step was a field evaluation where we had 9 pilot facilities to make, and the purpose of the evaluation was to measure performance in the hands of routine task-shifted providers. So in Malawi, we use a lake harder. We don't use laboratory staff. We have been using a lake harder because of shortage of laboratory staff for a number of years now. So that happened in 2021, and that was when we made a determination, when we were doing this field evaluation and the determination to use the 3-test algorithm. At the same time, we are also trying to consider what data tools we are going to use, because we knew that we would generate a lot of data, and we usually also generate data on supply chain. And you will all know that dHTS variables are many. So we proposed we agreed to use digital tools. And after the field evaluation, we moved on to pilot the digitized revised paper-based M&D tools. So we are using what we call ScanForm. It is an OCR AI. Thereafter, we proceeded to revising the curriculum to incorporate the new 3-test algorithm, updated all the M&D tools, then trained the providers. These were providers that are already providing services in the facilities. So they were trained in the new algorithm and the tools. And we started rolling out in phases. Currently, we are now in 601 out of 800 facilities that we have activated. So after the training, immediately after the training, we activate the sites. So those are done back to back. So what are the lessons learned? We have learned a lot of lessons, because now we have covered almost 80% of the testing data that we are expected to generate. So there are a number of lessons that we have learned. So the 3-test algorithm has saved us from misdiagnosis. If you look at data, after reviewing our data from November 2022 to April 2024, we have done 3.7 million tests. Out of those, almost 86,000 tested positive, while 73,000, so 86,000 tested positive for test 1 and 73,000 for test 1 and test 2. And we had 529 that tested positive for test 1, test 2, and negative for test 3. That says a lot. So we have saved 529, sorry, that's a typo, 521 from misdiagnosis. These were marked as inconclusive. So for the 3-test algorithm, you repeat the whole 3-test algorithm after 2 weeks, as I mentioned, and the DPS I already mentioned. But for the 2 tests, would have likely given a false positive result and started those clients on ARVs. That chart is just showing the distribution, nothing different from our data in terms of people that test positive, the population that where we see new infections. It's usually between 15 to 34, 35. So the 3-test algorithm has also saved us from retesting. Again, if you look at the similar data. So out of the 3.7 million, again, 86,000 tested positive for test 1 And we also have almost the 4,500 that tested positive for test 1, but negative for test 2. And almost 600 that tested positive for 1, test 2, and negative for test 3. So we're just here justifying how the 3-test algorithm has saved us from retesting. So the 3-test algorithm, the final result is a negative, but for the 2-test, final result would have been inconclusive and retest after 2 weeks. Again, the same data. I will not say much on that. So in terms of overall lesson rate, 99.96% that has been correct implementation of the 3-test strategy. So we have high quality training of providers, continuous quality improvements. We can also do remote monitoring via a dedicated national portal because of the digital component that we are using. But we have also had mentorship visits by the ministry and the implementing partners. Use of scan form, that's the digital innovation that we are using, has helped to get real-time data for quality assurance. So that includes individual level data, but also close monitoring of sites which are deviating from the protocol. So you can easily identify errors. I mean, the innovation, the digital innovation can identify errors. For example, if somebody has indicated a pregnant woman as a male, it is going to send that error, which has to be corrected. But also automatic standard monthly and data quality reports. I mentioned already about DQA. So the scan form has really provided us close to real-time data, but we don't have to visit the sites as used previously because the DQA is inbuilt. However, one thing that we have learned is that rollout to all sites takes time because you have to start with training all the providers in the 3-test algorithm itself, but also training them in the tools. And you have to activate just after the trainings, you activate. So it's taken us time to roll out. So we should be able to finalize the transition by June this year. But also there is the cost of transition. We had to retrain all providers, but at the same time, we have also noted that the addition of the 3rd test increases community cost by only 3% of the total test cost quantities. Of course, 3% may not be much because if you compare the 3% cost with the quality of the results, I think that's worthwhile. So this has been Malawi's experience. I think it has been a journey, but I think a worthwhile journey with a lot of lessons learned. And it's exciting because we have a lot of data using the tool. And one thing that we appreciate is using the 3-test algorithm with the reliable data tools for generating the data. I think it's a worthwhile investment for Malawi. Thank you.
Thank you. Thank you very much, Ross and Violet, for taking us through the 2 segments of this presentation. It's really key, starting with the first one and looking at a structured approach to really monitoring the quality of HIV testing services, and then providing really a global overview of performance of testing programs at the national level across the multiple domains that are reviewed in the community of practice. We also appreciate that I think countries then learn from each other to try and fix the gaps that they have in some of their domains, borrowing from countries that are doing well in some of those domains. And then the second component, a very exciting one from Malawi, looking at really the adoption of the 3-test algorithm and the benefits therein and how they went about it. And of course, it has generated a lot of questions in the chat. And so we will right away go to the questions in the chat, and please keep your questions coming. We'll deal with most of them, and thank you again to the CQUIN team and the Malawi team that are already dealing with some of the questions right in the chat. I've seen Dr. Matovu and others really responding to some of the questions already in the chat. Now, let me take us through a few questions, and I'll start with one that goes to Violet, so that we give Ross some time to catch up. So Violet, this is quite a good presentation. That's a comment from Mariam, and she's asking if you would like to share some of your experiences given the discrepancies in the scores that the same countries can turn. This year they are doing well in a certain domain, and next year they are not doing well. And yet some of those scores, if they are hinged on availability of policy documents, they should not be changing. Are you experiencing some of this? Because of course there are some scores that we expect to change if it's around turnaround time, or some practices that may have been left, and therefore the domain score can change. But some domains and some scores, especially the basic scores around availability of documents and structures, we do not expect them to be changing quite a lot. But your experience in implementing this CMM model in HTS testing services?
Thank you for that question. And yes, first of all, we have been able to experience variability in scores. And this mostly has been due to the fact that understanding of the domains, and also as countries continue maturing and being able to have that deep understanding of what exactly are we looking for, what are the scores that we are looking for, and able to conduct an in-depth analysis for the results that they have scored. Then sometimes we do see that maybe we scored a dark green, but when we look at the proportion or the data that we had used to assess our results, we note that there was a discrepancy or there was an inconsistency in what we utilized. Because one of the things that we do as CQUIN, as we said earlier, is that we do offer them technical assistance to help them prepare for the staging, where they're supposed to have the data source worksheet and all the documentation that they require, or the toolkit that they require to help them with the staging. But once in a while, you will find that probably there was a data point that was not validated prior to staging. And if they use it, and the next year they realize that, oh, probably we used this partner's data and we did not use nationally representative data, it affects their scores. So we do conduct in-depth review of whatever data they have submitted, and we are able to communicate areas that they require to review and help them be able to work on the inconsistencies as a country team. And once they have done this and they're able to then make the necessary corrections as the country team, and then they resubmit that particular document or that particular result, then we conduct the second validation to ensure that, you know, that now we have correct scoring of all the domains. And finally, now we have a consensus as the country teams, and we now file that particular result as their final result. But subsequently, once they have done this, they have realized that these are our gaps, then countries sit down and develop that, you know, this is our post-staging action plan based on the gaps that we identified when we did our staging for these particular domains. They are now able to sit down and say, we had a gap in XYZ. In the next staging, this is what we need to make sure is in place. Or also we had a gap because we don't have the right policies, we don't have the right, you know, our Ministry of Health is lacking proper documentation of our data. And these are things that they prioritize and now work together as stakeholders to be able to address those particular gaps. So it's a very engaging process, and we have seen many countries mature, and especially those countries that joined the network in the earlier stages from 2017 up to now. We have seen variability not in all the domains, but a few of the domains. But with time, now we are seeing better staging and better results because of this rigorous process that the countries have been able to go through. Thank you.
Thank you. Thank you very much, Violet. Let me get it to Ross and team. Ross, one quick question on the cost-benefit analysis of really getting to the 3-test logarithm. I know that this has been answered in the chat, but for the benefit of everyone, kindly, again, just help us get some of the benefits of using the 3-test logarithm versus the 2-test logarithm, even when the cost may seemingly be higher.
Okay, I think maybe our colleague can look at the slides at some point, but for Malawi, we have had experiences whereby we had litigations because of test results that were wrong. We have had the government has been sued a number of times. And I think now we are very comfortable with the 3-test algorithm because yes, there's a 3% increase in the cost, but you are assured of providing quality results to the client. You will not doubt the results. So quality, I think, is more superior compared to the 3% cost that we're incurring. In terms of sustainability, I think sustainability will not be compromised in terms of quality. With the sustainability, quality has to come in. My colleagues can also add if there's something that they want to add in terms of the cost-benefit analysis.
I'll leave that to Dr. Alale when she's doing our final closure. I give you about 2 minutes at the end, Dr. Alale, to try and also deal with that from WHO side and give it the guidance that is supposed to be taken up by every country. Rose, there is a question on the fact that the 3 kits, so the 3 test devices that you've verified and currently using in your test logarithm are all from the same manufacturer. And the worry is that how are you sure that the defected one is not carried forward, given that they're using the same manufacturing practice? And so there is that question, why did you go for kits that are only from the same manufacturer? What were your criteria for selecting a kit?
That's an interesting question. At the time, we started this process in 2019, but by that time, SD Bioline was not, the company was not yet bought by Abbott. So when we were doing the evaluations, we were looking at kits that were manufactured by different suppliers until when we had completed the evaluation and we were moving towards transitioning. That's when we saw Abbott buying that company. It's a Korean company that was manufacturing SD Bioline. So we proceeded because we were already in the process of transitioning. We have the kits are quality kits. I think there was a question about those kits. My supply chain team people are here; they can respond to that because these were just not picked anyhow. We picked those test kits. They were evaluated out of the many that were evaluated. Those are the ones that were recommended by the HIV reference lab based on the results for both the lab evaluation and the field evaluation. So we were guided by evidence. But my colleagues in supply chain may wish to comment if there is anything wrong, if it's about having test kit from one supplier. Do you want to talk about that, Stella?
No. So maybe just to add that you've seen in the presentation, our concern was about specificity and sensitivity for the kit, and we did not go into where the manufacturer is. And again, we are guided by WHO's guidance on which tests are already pre-qualified to conduct testing. So the issue about being manufactured from the same manufacturer, like the director has already pointed out, this came up later. And even at the time it came up, even up to now, we have no concerns about quality based on the item coming from the same manufacturer.
Thank you very much. And I think the last question, and very briefly from the Malawi team, there is a question from Anthony, and Anthony is asking the perception from the side of clients that they have multiple blood draws that should be done from them. How is this playing out given the rollout of the new 3-test logarithm in Malawi from the side of clients, if you've got any feedback from that side?
I have one of my colleagues who is responsible for service delivery. She will respond to
that. Thank you. In terms of service provision for HIV testing, we make sure that the compliance in terms of the guiding principles for testing, that is done, especially counseling. And when you are conducting the pre-test or providing the pre-test information, issues pertaining on how the testing is going to be conducted, those are discussed with the clients, and the client is informed on how many times she or he is going to be pricked, depending on the initial test result. So she's made aware and prepared psychologically for the number of pricks that she may have according to how the testing may go about. Thank you, and over.
Thank you very much. Let me hand it over to Alale or any colleague from WHO just to give us some insights into our session for today. But you can also provide some guidance on, is it still very optional that countries can continue with the 2-test logarithm, or there is a guidance that we should all but be moving in the direction of the 3-test logarithm? Dr. Alale, over to you.
Thank you, Francis. Thank you, Dr. Violet, Dr. Rose, for this very interesting session. So I would like to mention that our recommendation for moving to 3-test strategy has been out since 2019, and specifically we emphasize that this is regardless of prevalence in the country, because previously we had the differentiations, but now we are saying any countries using 2-test strategy to give a positive diagnostic HIV status to a client should move to 3-test strategy. And this is mainly important because we want to make sure we have a PPV or positive predictive value of more than 99.9%, meaning that if someone is diagnosed with HIV, we are more than 99.9% sure they are really living with HIV. This is also because of avoiding any challenges around the misdiagnosis. So we understand, 2 weeks ago, I was also in the CDC workshop, and we have been hearing countries concerned about why they have to move to 3-test strategy, the cost that might be implicated, the explanation to the clients that they have to now have sometimes 3 finger pricks. So we all understand those challenges, but having the higher PPV is actually our priority, and this is why we are recommending the countries to move towards 3-test strategy regardless of what is the prevalence in the country. And as also my colleague Celine mentioned in the chat, we know that we also have done a feasibility study to understand that the cost of the national algorithm is really driven by the A1 in the testing algorithm, because in the end, we will not have a lot of clients who will be needing A3. And as we mentioned, there are estimates of between 2 to 3% of the prices that is considered for 3-test algorithm is driven by the test tree. So the cost benefit here is kind of understanding that the national algorithm has a higher PPV versus having a higher cost. And of course, we know that a lot of countries have been using, for example, PCR or NAT for a confirmation, which is even more expensive and even more resource needs more resources, whereas using rapid testing can be even done at the community level. So that's mainly, and this is not replacing the need for, because I saw in one of the questions, countries are asking if Malawi is implementing retesting for verification before putting someone in lifelong treatment. So those are 2 different separate things. The retesting is really one component of quality assurance to make sure if someone is diagnosed positive and they want to go through lifelong treatment, they do the retesting to make sure that those human errors are kind of covered. And if still there are questions or doubt, the countries can always reach to us so that we can share with them more evidence and have more discussions.
Thank you. Thank you very much.
I've also seen that one of the countries is asking about the price of a scan form in Malawi. So maybe it's because we know that a lot of countries are kind of interested in automating their or using innovative tools for their country. So maybe we can ask Dr. Rose to respond if they have experience or if they can share us kind of generally what would be the implication of using a scan form at the national level. I think this is a good example for the countries.
Thank you. Thank you very much, Dr. Alale. And Ross, do you want to weigh in on the use of the scan forms?
It's really something exciting at national level for a low-income country like Malawi. I have Andreas Young, who is our SITA, who can speak on that very well. Andreas, do you want to respond to that?
Yes, on the cost of scan form. So the budget we're spending actually reduces significantly over the course of implementation. So the initial cost for the first year for about 800 facilities, 4.2 million clients tested per year, plus about 200,000 self-tests, because they were also covered by the scan form M&E tools, came to about $1 million. And the subsequent years, that reduces to about $240,000 for the entire national program for all of these clients. So it's a very cost-effective solution, a very low-cost solution by comparison to other digital kind of real-time point-of-care systems. Because the only hardware cost is in procurement of a simple smartphone, like a $120 smartphone for each facility, for each testing point, and then the supply of paper tools. The scan form team also deliver all of the data management. So it's a very convenient solution for a Ministry of Health that doesn't involve a lot of staff and ongoing cost for us to manage the data. So we have very convenient access to a data portal where all of the data ends up. So it's a very nice solution for a country like Malawi, we feel. Thank you.
Thank you. Thank you very much. Dr. Alale, you're up to wind up your submission?
No, just as I forgot to mention the last point on the manufacturers that was brought up. So we know that Abbott has been purchasing some of the companies who have been producing test kits, but just to know that the initial manufacturer was different. So that covers the concerns around why, for example, Malawi has selected test kits from same manufacturers.
Thank you. Thank you very much. And colleagues, we've come to the end of today's session. We're slightly overboard, but it is exciting that we've been able to cover almost everything. And from us, ASLM, and the team that organized this session, we wish you the very best of your morning, afternoon, or evening, wherever you're joining us from. And thank you for being part of this session today.